So without further ado, Dr. Spilarich is with our ASDO group, and she is an internationally recognized author and speaker on pharmacology and the care of medically complex patients. She has presented over 850 lectures and has over 100 professional publications. She's a professor and course director of clinical medicine and pharmacology and the director of research at the Arizona School of Dentistry and Oral Health. And she teaches, she works a little bit part-time in the special care clinic.
Okay.
She also serves as an associate director of the National Center for Dental Hygiene and Research Practice, and she's a part-time independent education and research consultant and practices dental hygiene part-time, specializing in geriatrics. So,
thanks everybody. Thanks Tanya. Hi everybody. Hello.
You must have more days in your week than the rest.
Yeah. No, I don't. Clearly, I need a hobby. Anyway, thanks everybody for spending your lunchtime with me. I'm Ann Spilarich. I know many of you here, and hello to those of you who I haven't met before. I thought we would pick a topic that is near and dear certainly to my heart, but certainly to everyone's heart, everybody who's involved in patient care, but also I think kind of from a personal perspective too, some considerations if you are a parent, and also I think some considerations if you are caring for an older adult in your family. We have to sort of hit on a lot of topics that I think are very relevant to all of us. And let me just start out by saying that I don't really think that much of what we'll talk about is new, but what I hope to do is to maybe give you a different contextual framework in which to message your medication safety behaviors and educational messages to your family members and to your patients. I also thought today we should take a few minutes to make sure everybody's very familiar with our new state opiate prescribing guidelines because they cross disciplines. So this is a wonderful forum to make sure everybody knows where to find that information and how it may impact what we're doing in each of our respective professions. So I brought a lot of material. We'll move kind of quickly through it. We'll talk about the fact that medication error prevention is front and center across pretty much every professional group. And we know that rates of medication errors continue to increase despite a variety of safety mechanisms that we have put in place. And so it really falls to all of us to kind of self-evaluate what we do every day as practitioners, but then also what are we doing in our clinical facilities? What can we be doing to help our patients prevent medication errors at home? We know everybody's using more medications across the board, and of course nobody uses more drugs than Americans do. We bypass pretty much every other society in terms of numbers of drugs used. And then we'll also talk a little bit too about the issue of drugs in the environment and what do people do with all these drugs they hold on to and how do you get rid of them in a safe way. So that's kind of what I have planned. So we'll start with a quiz. I mean, we are in an academic institution. Okay. So here's the first question. Are you ready? What's in your medicine cabinet?
Lots of old stuff.
Okay, so I want you to yell it out. I want you to, and those of you who are going to watch us later on film, you have to be doing this also at home for yourself. So let's hear it. What's there? Ibuprofen, amoxicillin, Tylenol, right? Vitamins, okay, right? Heard some opiates. How about some maybe antihypertensives? Lisinopril, there you go, right? Okay, next question. What should never be in the medicine cabinet?
Expired drugs.
Tylenol, ibuprofen, expired drugs. Anything else? Well, you know, there's a big question about whether drugs should actually be in the medicine cabinet at all, right? Because of the environment where most of us have our medicine cabinet. It's really not conducive to good storage, right? It compromises the integrity and the shelf life of lots of medications, especially if you have a bathroom that has no ventilation in it, right? Very hot, very moist, humid environment. But believe it or not, that's not what the answer was that I was looking for. This was the answer that I was looking for, which is kids, right? We're going to start to talk about kids a little bit, and the whole notion everybody should know that children's abuse of prescription drug medications, as you know, is off the charts and continues to rise. We have a big problem with it right here in the city of Phoenix. Our state is a leader, sadly, in abuse of medications. the thing about it with kids is that they no longer need to go anywhere else to get them. They don't have to ask for friends. They don't have to buy them on the street. And this whole topic of multi-generational households, this re-emergence of, mom and dad and grandpa living with us, same thing. Now we have lots of drugs in the house at all times. And of course, this is one thing we always have to be familiar with if we're prescribers, watching what we are prescribing, the quantities that we are prescribing, this idea that people aren't hoarding these drugs at home. It is the leading cause now of visits to the ER among pediatric patients. So, by the way, this is nicknamed farming, if you haven't heard that before. It's P-H-A-R-M-I-N-G, farming, where kids raid the medicine cabinet at home, they bring them all to school, and they just swap for the pretty colors and shapes and sizes, and they take them, and then they see what happens. Right, farming. It's a big risk behavior for kids. Also, just to kind of let you know, prescription drugs comes in fourth in terms of substances that kids abuse, behind alcohol, tobacco, and marijuana. So continues to be a major issue for us. I also put inhalant use there, which peaks at around the age of 8. And of course, this is another substance that lots of us have at home with our cleansers and spray paints and things like that. And I think we all know that certain kinds of substances now, like spray paints, are behind the cage, if you go to Home Depot or one of these kinds of big box improvement stores. But there's a lot of other things that are not behind the cage, and kids are very, very creative at getting their hands on things, right? So opiate overdose, if you look at the bottom of the slide, causes more overdoses in adolescents than street drugs combined, cocaine and heroin. Heroin is the #1 drug that's abused in my local high school where I live. And when there's money and opportunity, you'll see heroin because it's a lot more affordable than cocaine and some other kinds of substances. I thought we would just take one quick little sidebar chat to talk about dextromethorphan, which is in a lot of popular cough medications. Kids nickname this Dex. And we have a phenomenon in kids called robotripping. Some of you might remember, if you've ever used this kind of cough medication, when you use it, it tends to sedate you a little bit. It crosses the blood-brain barrier, makes you feel a little dizzy and woozy. Most manufacturers of products that contain dextromethorphan put other substances into them, similar to syrup of Ipecac. And what does that do? Makes you vomit, right? And that's intentionally put there in case somebody's going to accidentally overdose on it. It's protective. So kids know this too. So what they do is they go buy cough medication and they slam it. They drink the whole bottle down. They hold it in for as long as they can, and then they vomit, and then they hallucinate. And that's called robotripping. Okay? So anyway, the fun never ends. Kind of not really sure why that's fun, but anyway. So point in fact, to illustrate the concept is you don't have to go and get street drugs to do it. You can walk in any pharmacy and get these kinds of things. Also, to let you know, the other big popular drug that's over the counter is Coricidin, HBP. You all know Coricidin. You recognize it as a cold medication. There's a formula for it that's targeted for people with hypertension. And this also contains dextromethorphan. And so you get the same kind of idea. What the kids do is they take 20 tablets to get the dose that they're looking for the central effect. And by the way, I'm a firm believer in listening in on children's conversations and going through their backpacks and snooping and all those things, because I think you also have to know what the language is that kids use. So when they often will call these tablets Skittles, because the Coricidin tablets look like the little Skittles candy, right? So I have to kind of listen in and hear what they're talking about. Triple C, that's Coricidin, or Skittles, that's the dextromethorphan high. And of course, all over the counter. Inhalants we talked about. Why is this really important? Inhalant use is really, really common. It's a lot more common than we realize. And in fact, now manufacturers of these products add bitterants to them, so to try to deter kids from doing this. But it's really important to all of us in medicine and dentistry, because what the difluoroethane, the chemical that's in most of these aerosolized products, does is it sensitizes cardiac muscle, the myocardium, to epinephrine. And so then if we stress the person, or certainly for us in dentistry, when we give epinephrine to somebody, we can actually cause an adverse cardiac event. And how do kids die from using inhalants is they have a heart attack. Okay, so I just like to kind of bring everybody into the loop about this. Everybody looks a little shell-shocked right now. I mean, this is not a good conversation, but it makes us think very differently, about how we keep things at home and access to things. A few other things to remind everybody, which I think we all know, is that because in children their mucous membranes are much more permeable than adults are, medications cross more readily and faster than they do compared to an adult. And so we have to be mindful of how much we're giving them. So we typically have to lower the dose, and we know that the dose on many OTC things is determined by the manufacturer. That's developed through testing. Most of our databases that we have here at school, like LexiComp, will actually have calculators built into them, and sometimes they actually will provide a dosage table based on the child's weight. And of course, everybody knows the problem with kids is that many of them are approaching adult weights, right, because of obesity. So it can become a little bit tricky. Remember, the pediatric dose should never exceed the adult dose, right? But we tend to be using higher limits in children now because of their body mass. So always safety first, is the dose is based on the weight of the child. And typically in over-the-counter preparations, you see that the pediatric dose is about half of what we use in the adults. But there are variants in that now, and there's actually some discussion about should we have what we call sort of junior dosing, like an intermediate pediatric and then between to the adult, to kind of compensate for some of these things. The Poison Prevention Act has been around for a long time. This is what mandates safety caps on medications. It's an important aspect of safety to prevent accidental overdose. Please, for those of you who are writing scripts, if you're treating a lot of older adults, maybe you have people with arthritis or neuromuscular function problems, loss of mobility, you can write on the prescription to substitute the cap. And I think it's really important that we all teach our students that prescriptions are also opportunities to communicate with the pharmacy. So if you want to write something on there, a patient has liver disease, a patient has kidney disease, a patient has this problem or that, tell the pharmacist so the pharmacist understands why the dose might look different or why you don't want a safety cap. Bring that pharmacist into the conversation. Pharmacists are our friends. I can't ever say that enough, and I think that we forget that. Ultimately, they become the police, right, of everybody's behavior. So bring them in up front. It's always a good thing. Conversely, when we talk about who's the other big at-risk group, we all know it's older adults, and of course the normal physiologic changes of aging increase some risks that we see with medication use. We know that liver function and kidney function decline with age. That's a normal part of aging, which is why that in and of itself is often a reason why we have to lower the dose in older adults, and then coupled with the fact that they often have pathologies that affect those same organs, affects metabolism and clearance. They have less body mass, lean muscle mass, and more fat, so they're much more likely to store medications that are fat soluble, and drugs will appear more concentrated in the circulation. Just to kind of remind everybody that it isn't the drug that's bound to the plasma proteins within the circulation that's what causes the effect. It's the amount of drug that can leave the circulation to interact with receptors on target tissues. So the more drugs an older person takes, the less quantity stays bound in the circulation, because there's only so many X number of binding sites to go around. And as you get older, the number of those sites to bind them up decreases. So you have more drugs that are able to leave the circulation and do their thing, which is why one of many, many reasons why older adults typically have more adverse drug events, because you're seeing more side effects, right? Please.
About what age does that start to happen?
Yeah, that's a really good question. So I'll repeat the question for the camera. So at what age does that start to happen? I don't think we really know, but I do think what I've certainly read is that you start noticing it in the general population by the late 60s, certainly markedly so in the 70s. But I think we have to remember that there's so many variables that also account for why we see adverse events in older adults. This is just one of them, right? Just one of this normal physiologic changes, and the slow diminishing production of plasma proteins. And then one quick point here. If you watch television, you should be convinced you have acid indigestion. I mean, really. I mean, it's a huge direct-to-consumer market, and it's really, really targeted to older adults. And my older adult patients, they carry all this stuff with them, Rolaids and Tums and Mylanta and Maalox, and they don't ever think to even really tell us about them. It's just sort of a normal part of what they do. And that's as you get older, you do have more acidity in the stomach. But what's important to understand is it doesn't necessarily translate into pathology, right? But that's a way to get people to use an antacid, right? So, and when people use antacids, remember it changes the pH of the stomach, so it does change the absorption of medications. And because people don't even think to talk about antacid use, a lot of patients will swear upside down and backwards that they're using the medications we prescribe to them and they're not working. And why is that? Okay, it's probably because they've screwed around with the pH of the stomach. And people tend to take all their medicines at the same time. They put them out on their placemat and they take them at mealtime, and a lot of those things don't play nicely together. And here's a really good example of that. So just some interesting conversation to have with an older adult. I always ask patients when they say, these are the only things I take, I always prompt them about antacids because I know it's highly likely they're going to be using them. In dentistry, FYI, for our non-dental colleagues in the room, we don't really like those antacids because a lot of them have sugar in them, and they really contribute to tooth decay in older adults. All right, prescription drug use, as we know, I don't think is a big surprise in older adults. They really sort of corner the market in terms of the percentage of drug medication users. However, in a very large percentage of them, the use of those medications is inappropriate. We also should know that about a quarter of older adults use what we call psychotropic medications, or drugs that affect the central nervous system. So again, the more they take and the higher the dose, and then also throw in a little alcohol into that mix, we start seeing a lot of central nervous system side effects in older adults. They tend to be additive, right? And what are some of these kinds of substances? Opiates for chronic pain, benzos for anxiety, and sleeping pills. Older adults typically have problems with insomnia. So using drugs like Ativan and Xanax are really, really popular choices for sleep aids. Alcohol, of course, self-medicating. Those of you who came to listen to me talk about substance abuse in older adults, we talked a lot about that the vast majority of older adults are regular drinkers, and they drink earlier in the day, right? And they also have not changed their drinking behavior. So whatever they did when they were in their 40s, they do the same thing now in their 80s. The problem is physiologically they can't handle the same dose of the alcohol. So they don't realize that the dose of their alcohol is affecting them and can actually worsen so many of their underlying physiologic conditions. Alcohol and tobacco, chronic lifelong problems in older adults. I know we don't really think about them as drugs, but across the board, they cause more medical problems than anything else. And dare we even go here, marijuana, right? Marijuana use is on the rise in children, and we also see, of course, on the rise in older adults, and whether or not it's medicinal or not sort of depends on who the person is. But it's kind of interesting in these sort of anecdotal studies of marijuana dispensaries in California, who is the face of the shopper there? It's not a teenager. They're all, boomers and older, right, who are coming in. So anyway, onward and upward. I think the take-home message for all of us in healthcare is to watch for redundant prescriptions, right? So I get a prescription for a benzo from my dentist, I get one from my physician, I get one from my nurse practitioner, whoever is writing for these things, and what are they getting and why are they getting it? So I think it's prudent for all of us to kind of do a cross-check and what do you already have? And of course, this is the advantage of moving into the electronic health records era, where we will have databases in place that can kind of cross-check some of that stuff for us, right? So same kind of rules apply with older adults. Because of the physiologic changes, we have to lower the dose. Super easy to overdose an older adult. I know in the special care we talk about this a lot, where a lot of the antibiotics we want to use for orofacial infections, we've got to lower the dose for that older adult, and also their kidneys and livers aren't working so well, and they can't handle that typical kind of dose we would use in a younger individual, right? So the greater the number of pharmacies used, right, the greater the risk that there will be adverse events in the individual. Please.
What age are you
defining as a geriatric?
Well, that's the magic question. At what age is someone geriatric? Well, believe it or not, I'm an older adult. I'm an older adult. I'm the youngest of the older adults. I'm the tail end of the boomers, right? So I actually fall. I know everyone's people are like having a moment now, some people in the room. So if you are 50 and older, you are an older adult. If you look at, and we have really like 4 cohorts of older adults, as we all know. And boomers are really different from people who are in their mid-70s to mid-80s, who are very different from the people who are, in the next group, 85 to 95, and then those who are older than that, right? So I actually have a patient who's 103 who walks to his appointment, comes for routine preventive care. Okay, so I hope to be that person. Okay, that's a nice thing to go for. Another medication error that I think often we miss is falls. There are a lot of drugs that contribute to fall risk, many, many, many of them. And it isn't just, of course, in medical settings, but also in the home. And I always like to ask everybody time to do a little self-assessment. If we have somebody who would fall in one of our buildings here, I know we have all kinds of policies and this and that and what happens, but also kind of in the moment, what happens? Do we have a pull cord in the bathroom? Do we have a way for that person to communicate that they're down? Do we have a way to get into it? I always like to, when I give this talk or a variant of it to a group of professionals, I always ask everybody, where are the hinges on your doors? Are they on the outside of the locked door or on the inside of the locked door? And that applies to your house too, because if the hinges are on the outside, somebody goes down on the inside of a locked room, fire department, we can remove the hinges and we can lift the door off from the outside. Otherwise, we have to bust the door down, right? So think about your own home environment. Everybody has locks on their bathroom doors, but do you have key entry from the outside? So if somebody, mom's spending the winter with you as a snowbird, she locks the bathroom door, she goes down, do you have a way of getting in? And these are just everyday kinds of things to be thinking about, but I think we should talk more about them. Right. Okay. All right, so we already talked about liver and kidney disease, and obviously the big contender here that we have to worry about is diabetes, right? So my philosophy is practice. My students know that I think everybody has heart disease and diabetes until proven otherwise, and that's really how I go into the appointment. Because for most people, unfortunately, it's true, working with older adults, and really just to be mindful of the fact that I think a front and center complication is the diminished renal function, and it really affects us on so many ways. All right, so I promised you we'd do a little update about what's happening with opiates. Now, I think everybody knows how the rate of accidental drug overdoses has been slowly increasing. But what I want you to notice, up until 2007, the red line is the drug-induced deaths. It was still fairly well behind motor vehicle fatalities. And then, of course, just a few years ago, it far surpassed. So we are now living in an era, this is CDC data, where we now know that drug-induced accidental overdoses, right, are the #1 reason for deaths from an accidental cause. What's even worse here in the state of Arizona is we rank 6th in the nation. So we have a really big problem right here at home. And again, I think if you look at opiate, unintentional overdose, again, far surpass cocaine and heroin. And these numbers have been on the rise. And I don't think any of this is a big surprise. Most major health organizations, the CDC, the World Health Organization, and now the White House have issued recommendations and directives for getting a handle on the use of all kinds of drugs. We have another one that's similar, which is now related to antibiotic stewardship. This is another group of drugs coming under this issue of using them wisely and safely and appropriately. Out of the White House report, 1/3 of people over the age of 12 for whom they're using drugs for the very first time began using first a prescription drug non-medicinally. So that is in line with what kids are still doing, right? So they abuse a prescription drug. Most people who abuse them get them from friends or relatives. They're not doctor shopping. Only 5% of them get them from a dealer or over the internet, and prescription drugs second most abused, second only to marijuana. We're also, just the take home here is we're also seeing a big rise in the military of prescription drug use. And of course, many of us work with a lot of young veterans, and I think this is something we have to be aware of. The milligram per person use of prescription opiates, look at this, over a 10-year window of time, 10-year period increased over 400% in the military. Okay, so something is going on. This population of young vets has more issues than any other population we have seen since the Vietnam War. And I think everybody's kind of familiar with this, that a lot of people are self-medicating with drugs and alcohol for PTSD and other kinds of issues. And so really, this and many other reasons was really the driving force for the Arizona guidelines. We actually became the 8th state to implement recommendations that cross all disciplines for using opiates. And I had the privilege of representing AT Still and dentistry at the summit that was convened here in our state. And it was very interesting to be in a room where everybody was talking about, well, this is why we need them and this is why we need them. And then of course the ER docs were saying, we're sick of cleaning up everybody's mess. So we really need to do something about this. And of course, as we know, here in Arizona, we have so many people who don't have a medical home or a dental home. And so they're buying stuff on the street, or they're going to the ER, or they're going to pain docs, and they're hopping from place to place, trying to get their hands on a lot of these kinds of substances. So, and by the way, FYI, just last month, Pennsylvania just came out with them. So we're now up to about a dozen states who have these guidelines, and I think you're going to really see it be a national trend. And you can't read this slide, it's not why I have it here, but I want to tell you where you can find them if you haven't seen them before. This is the Arizona Department of Health Services, and there's a link sort of right at the top that is clinical guidelines and recommendations, and you will come right down to where the guidelines are, and you can open them. The other place you can get them is from the Arizona Pharmacy Association, and they have all kinds of wonderful resources there about medication safety and where you can get more information as well. This is also where you find out and how you can enter into the prescription drug monitoring program in our state. Just kind of an FYI.
Is Missouri part of that?
I'm sorry?
Is Missouri part of the?
No, Missouri doesn't have guidelines. Not yet. I know a lot of states are working on them. It's kind of interesting, like if you look at the sort of northwestern part of the United States, it kind of started up there and came sweeping down and over Oklahoma, and now we're starting to get some states with Ohio, Pennsylvania, New York, I think, is working on theirs. So now we all know that if you are a prescriber, you are mandated to, if you are licensed in the state of Arizona, to be enrolled in the monitoring program. In other words, you have privileges to get in and out and look up patient histories in the monitoring program. But what we find in this state is that very few professionals actually do that. So it has not changed and translated into a change in behavior. So we're not really sure why that is. My colleagues in dentistry are even further behind than our medical colleagues are. So that's something we have to be working on. In our recommendations for this state, there are 6 specific things that we want everybody to follow. And number 1 is obviously use opiates for acute pain. And there are very few times and very specific situations when opiates are used for chronic pain. So in the vast majority of us, when we're going to be writing for procedures, it should be for short-term use only. I teach the dental students for 3 days use. And then if somebody needs it beyond 3 days, the patient comes back in, they get reevaluated and make a decision about them. There never are drugs of choice for us in dentistry because they're not anti-inflammatory, and almost all of our pain is inflammatory in nature. So we have to be quite mindful. The second recommendation is that if you're writing for them, the number dispensed should be no more than the number of dosages that is needed. And what we're really trying to do is to break this hoarding of opiates. So we don't want people to have leftovers, right? And a lot of people have them at home, right? And that is, you should be able to justify the quantity based on how severe the pain is anticipated to be and the nature of the procedure. The third recommendation is that we have to counsel patients on the following: that sharing is illegal, that they have to be stored securely, that they have to be disposed of properly as soon as their indication for use has passed, right? That they are supposed to be for short-term use only, and that they have to be careful driving and operating machinery, right? And this is a big one because sharing, pretty common. Those of you who know me personally know when I was at physical therapy, I love to tell the story. The guy next to me, we were both on a treadmill rehabbing our knees, and the guy next to me said he gave all of his Vicodin to his kid to take to school, and he made $600 selling the rest of it. Okay, that's a felony, by the way, when that happens. So I know. Then I was sort of like, well, where should I start this conversation? Oh my. All right, so it happens all the time. Opportunity knocks, sadly. All right, so long-acting opiates should not be used for the treatment of acute pain and postoperative pain except in opiate-intolerant patients, and then some other kind of situations. So here the exceptions would be like end-of-life cancer pain, those kinds of situations, and typically that person is going to be in a medically supervised setting like an acute care facility, right, or in hospice care. Continued use should be considered carefully, and the person has to be reevaluated. So again, if somebody, like in our discipline, somebody needs more than 3 days, we evaluate them, we make the decision. We might give more, or maybe ideally we would switch them to something else that's more appropriate for the nature of our pain. And then again, everybody who is going to use opiates with a patient is supposed to be checking in and using that monitoring system. So those are the recommendations from our state. If you haven't had a chance to read that report, they have kind of a crib notes version of it. It's maybe a little bit easier to read. You can go to one of those 2 sites and check them out, and I really would encourage you to do that. So everybody is supposed to avoid overprescribing, right? Limit the quantities and help move past this big problem. In our state, really big problem. All right, so moving on, I already kind of talked about alcohol and tobacco as causing more medical problems than all of the drugs of abuse combined. But let's move off the drugs of abuse and just talk about a few other drugs in the medicine cabinet, because these are some that you all mentioned. So actually, isn't that good? I picked slides. You were right on target. Very good. Of course, we all know about the issues right now. The #1 cause of acute liver toxicity in this country is from too much acetaminophen, right? And why do we have all of these, what I like to call Tylenol eaters? It's because they were ibuprofen eaters and they burned out their stomachs, and now they had to become Tylenol eaters, right? So we've now moved from one problem and we've moved them into another generation. Now, FYI, 40% of over-the-counter cough and cold and pain relievers contain acetaminophen. And so it's really pervasive. And the McNeil Laboratories, who's the manufacturer of the Tylenol brand of acetaminophen, became the first company to lower the maximum daily dose. It used to be how much? What was the upper limit? 1,500. Nope. Total upper limit for the day. 4,000. It used to be 4,000, right? And now they've lowered it to 3,000. But it's always been 2,500 if you are a drinker. Okay, so, and of course, people don't think drinking alcohol is drinking alcohol, much less using a drug, right? So people always say, well, how does somebody get to that point? And it's super easy. Extra strength Tylenol is 500 milligrams. So you take 2 at breakfast, and 2 at lunch, and 2 at dinner, and 2 at bedtime, and you are at the upper limit, right? And then you would take a little Excedrin for your migraines, and a little of this for your cold, and a little of that, and then I go to the dentist, and I have a tooth extracted, I get a little Vicodin, and before you know it, people are getting too much, right? So. And everybody remembers that the FDA actually required all the manufacturers who make combination opiates with acetaminophen to limit the dose of the acetaminophen. It used to be able to get up to 500 milligrams. Now it maxes out at 325, right? And that's a direct outcome of this problem of the hepatotoxicity, right? Very hard on the liver. Here's ibuprofen. I always say if we did an experiment, if we put ibuprofen in a candy dish, we could put it right in this room before the medical students come in. And we could put it in a little candy dish right here, and it would be gone by the end of the day. Everybody loves ibuprofen. Everybody take a little bit. I spoke at a big meeting on Friday in Dallas, 500 people in the room. I said, show of hands, let me see how many people have ibuprofen on their person right now. 3/4 of the room. Most of them, women. Right? It's great. You go to a conference, you get a headache, just turn to the person next to you. Everybody's got drugs on them.
Carry for everyone.
You have to carry for everybody. Have to go to Costco and get one of those really big ones, right? And people don't really think ibuprofen is a drug. I mean, they absolutely do not. And nobody takes the analgesic dose. You know, there's a ceiling effect, meaning that once you go beyond this dose, the analgesia tends not to be any better. Does anybody know what's that dose?
6 times.
No.
8.
Nope.
4.
4. Once you go above that, you get the anti-inflammatory effect, which secondarily has the analgesic effect, because you're getting to the source of the pain, right? But everybody, you know, I have a headache, take 4. You know, I worked out too hard, take 4. Oh, it's 4 o'clock, I better take 4. Right. I mean, everybody loves it. So the other thing people don't realize is that ibuprofen has been linked for a long time with increased cardiovascular risks, heart attack and stroke. It also interacts with a ton of medications. If you, as a healthcare provider, are recommending ibuprofen to your patients, I want you to make a commitment to read the monograph. It's been a while since you have. You might be quite surprised at what's changed in it. So for example, here's just some of the kinds of interactions we see. This is one of those times, absolute no-no in people on lithium for manic depression, because lithium is a very toxic drug. It's super hard for the body to clear it. You overdose on it pretty quickly. But if you take ibuprofen with it, it prohibits the kidney's ability from removing it from the body. So before you know it, that person really gets into a lot of trouble with toxicities. It also monkeys around with a lot of commonly prescribed blood pressure medicines. And so this is what we see every day. People swear upside down and backwards, yeah, I'm taking my blood pressure medicine, and then we take it and we go, oh, how come you're not really in range? And again, because they're ibuprofen eaters. This is the first question I asked, right? So just kind of a little bit of a take home for this. You really are not supposed to drink with it, because it's not only hard on the kidneys, but also hard on the liver. And of course, as you know, if we all started taking ibuprofen right now, every one of us eventually would end up with a stomach ulcer. We would all get to that point. We might get there at different rates. Those of us who are drinking, right, will get there sooner, right? So no drinking, it's a tough thing. Just last month, the FDA changed the labeling on all NSAIDs to show that the risk for heart attack and stroke was actually higher than they once thought. So it actually now has manifested in a labeling change on those medications. So you can Google FDA and NSAID label, and you can read that if you want more information about that. Nobody said aspirin in the medicine cabinet. #1 self-prescribed drug, as you know. The cool thing about aspirin overdose is it's one of those drugs where people can actually tell us when it's happening. And what's the big thing? Right, ototoxicity, ringing in the ears, right? Tinnitus for my audiology buddies here, right? Not tinnitus, which is what all of us in dentistry learned how to say, right? It's tinnitus. We learn how to say it correctly. And just to remind everybody, you should be asking your patient, does your physician know? Does somebody recommend that you take this aspirin? And remember that if 81 milligrams is good, 325 is better, 650 is even better. Right? We like excessive quantities of stuff, and people tend to take large quantities of it. Quick comment about herbal and dietary supplements. We all know that these products are used across all age groups. College students, so we've got a lot of students on our campus who are probably using them. Boomers are one of the biggest groups of dietary supplements, but we even see it used up until well into advancing age. I think if you take a look at the list, the most popular products in adults, everybody's not surprised, right? Fish oils, glucosamine, anything there kind of surprise anybody on that list? No, I don't think so. And then, of course, 50% of adults use vitamins and minerals of some type or another, calcium and B complex. I always like to just say calcium has never been shown to decrease fracture risk. There's no evidence to show that. And I think that often really surprises people, because in most health recommendations, calcium is sort of front and center. But really, it only increases your bone mass by about 17% and really has not translated into change in fracture risk. So I think you have to kind of weigh that wisely. In fact, there are very few people in this country who are actually calcium deficient. The ones who are people who have, wait for it, diagnosed by blood test vitamin D deficiency, not like I think you're vitamin D deficient, like how many people are, right? And you should probably take a supplement. You have to have a test, right, to show that. And then the other people are, believe it or not, girls, and specifically Caucasian girls. That's what the literature shows. And that's because they mistakenly believe that the only source of calcium is high-fat dairy, and they don't eat it to stay skinny. Stuff to think about. Okay. All right, nobody's surprised that in addition to polypharmacy, we also have polyherbacy, right? So the more herbs you take, the more likely it is you're going to have a drug-drug and a drug-herb interaction, and that's all I wanted to say about that. Here's a few other dietary supplements that are really popular right now, especially in older adults. Cod liver oil because everybody's constipated, St. John's wort for depression, saw palmetto guys for prostate health, right? These are kind of some of the big ones in addition to the ones we looked at earlier. There is one study which I really love that was published in 2012. It is the only study of its kind. And what the investigators did was they went through the entire scientific literature and they pulled out every paper that documented a drug-herb interaction. So it's the only paper where you actually have a collection of the existing body of evidence. And what they found, look at this, almost 1,500 pairs of herbal dietary supplement with drug interactions, over 200 dietary supplements implicated, and over 500 drugs. The greatest number of supplements implicated in interactions: St. John's wort, magnesium, calcium, and iron. So all the ladies, of course, that were target marketed to use those in women's vitamins, right? And ginkgo, which is for what? Memory. And you know, multiple randomized controlled clinical trials to show it has no effect on memory. And you know how, like, sometimes you're really disappointed in the evidence, and the older I get, the more disappointed I am in those studies, right? It's a bummer. Okay. One other thing to remember, I'm throwing a lot at you pretty quickly, is that Coumadin has the greatest number of drug interactions, but also the greatest number of herbal and dietary supplement interactions as well. And of course, we have so many people on Coumadin because of atrial fib and MI and history of strokes. So this is going to be something that's relevant to everybody, right? And in your specific discipline. About 100 herbal supplements are implicated in altering bleeding. I would say there is about 50 of them where we actually have some data. Some are pretty well documented. I always say that if the herb starts with the letter G, it should raise a flag to you. Garlic, ginkgo, ginseng, those are kind of some of the big ones on the market that we know alter bleeding, right? And we all know, people have no idea that it does this, and they're on eating a lot of ibuprofen, they're having fish oil, they're doing vitamin E, they're on Plavix, they're on Coumadin, and we all know the deal, right? So recommendations are now that if somebody has to have surgery, they should go off all herbal supplements 2 weeks before the procedure. Not 1, 2. And it's because a lot of those same supplements actually monkey around with the liver, and it can change the way substances are metabolized, including some of our general anesthetics. So 2 weeks before, it's always good to have signs up in your clinical setting to remind people of that. Okay, so I like this. This is how well can you read this label? It's ridiculous, right? So I mean, they have their place, but I mean, it should just maybe be a color, because I don't think most people can actually even read what they say, and I don't think most people do, right? So anyway, rules to live by as we wind down and everybody goes back to work. Literacy is a big one. The big promotion in health right now is teach back, right? And in our context today, when I say, Monica, I'm giving you this drug for this reason, she should be able to say back, this is my amoxicillin, I'm supposed to take it for my infection, and here's how I'm supposed to use it. And if I give her more than one drug to use, she should be able to say, this is my pain reliever, and this one's my antibiotic, and this one's for this, and this one's for that, and how to use them. Teach back is really important for reducing medication errors. Also, the FDA has some recommendations. Everybody should be able to name their drugs, why they're using them, essentially how to use it, if there's anything that they have to know about it, like what to do if they miss a dose, or don't eat this food with it, or whatever it is, and how to keep it safely. Storage becomes an issue. We mentioned earlier, medicine cabinets are really not good places for drugs. If you're not sure about how something should be stored, you can check with the manufacturer on their website. You can also check with the pharmacist or the FDA. avoid human conditions. In medical settings, a lot of people, believe it or not, keep stuff above the autoclave. When the autoclave vents, whoosh, you know, it's like the worst possible place, right, from the steam and humidity to do that. As we all know, some drugs are light sensitive. For us, I think in healthcare settings, especially in schools, we've moved away from example of nitroglycerin in the little tablet form in the little vial, because of course nitro is very light sensitive, and instead we go to the spray because it works the same way, but it has a longer shelf life and it's easier for us to manage, right? And everybody knows we don't keep drugs where patients go, right? All right, don't use expired drugs. This is a big one for me with older adults, because people don't like to throw stuff away, and they go, well, does it really not work? Because I paid $35 for it, right? And the idea of this, of course, is that the product does have a designated shelf life. In reality, in the context of aroma professionals, it's probably beyond the date, and it does vary by product, but the problem is over time it's likely to lose its potency, and some substances do start to degrade, and there are some cases with expired drugs where people end up with issues of damaging the liver or damaging the kidneys. So I always think it's better to have sort of an all or nothing rule of life in this context and tell people to get rid of their expired drugs. And then again, just to show you, you guys all know this, but how to avoid accidental overdose. So the FDA has wonderful recommendations of what patients should be doing. But I did want to just mention this bottom one, is to remind people to use the delivery vehicle that comes with the drug. And this is really important for children. You know, we had a big issue a couple of years ago where pediatric stoppers for drug delivery were not controlled, they weren't regulated, and so there was so much variance in the manufacturing that, you know, you've all used a dropper, so you squeeze one with the idea that only a single drop would come out, but when the person would actually squeeze it, the whole thing would empty, and the child would end up getting, you know, 1,000 times what the dose was supposed to be. So now the FDA has stepped in, and now it regulates the pediatric dosing devices. So I think it's really helpful, and plus people don't always know, like, use a teaspoon and they pull out some big gigantic, you know, soup spoon out of their kitchen drawer and they don't know what they're doing, right? So, okay, so blah, blah. I think we talked about all this kind of stuff already. What do you do with stored drugs? And there are issues with this. This is a big conversation, because the real critical part of it is, if you're hanging on to drugs, what does it do? Not only risk for older people and children, but also your pets. Like, there's certain drugs, like a single dose can kill somebody or a pet. And opiates, of course, sort of fall under this category. And then, of course, they get in the wrong hands if somebody's looking for them to, you know, abuse them. And of course, then everybody's worried about what's the effect on the environment. Now, a lot of wastewater treatment plants will remove drugs. You're not really supposed to, you're not really encouraged to wash them down the sink or flush them down the toilet. The first choice would be what we call a drug take-back program, and you can go onto the FDA's website, the DEA's website, and type in your zip code, and they will tell you when the drug take-back event is in your community. I live in Cave Creek, here in the northernmost part of the city. We have a monthly drug take-back day, and it's on, I think, the third Saturday of the month. And then our local police stations have locked boxes where you can drop off drugs anytime you want, 24 hours a day, no questions asked, which is really, really nice. And I forget I read something about Arizona. It was some unbelievable amount of drugs that were turned in. I want to say like 6,000 tons of drugs in a year or something. I mean, like, pills don't weigh anything. You go, how many pills is that? You know, it was some crazy off the charts thing. Pharmacies have them, but I'll tell you, a lot of consumers don't use them because often you have to pay a fee. This is actually my Safeway. I took a picture of it with the pharmacy so I could teach with it. But there on the DEA website, there are disposal steps, and what they want you to do is take them out of the container, take the label off the container. If you can't take it off, use a Sharpie, a black indelible marker on them to cross everything out. You can wrap them in duct tape. Don't you love duct tape? Here's yet another use for it. Actually says that here. You've all heard mixing with coffee grounds or cat litter or these kinds of things to discourage use. You can go onto the website and they will tell you how to dispose of certain medications. They've really built this out because this is such a concern for people. And then sort of last but not least, there actually are drugs that are supposed to be flushed. because of the risks to keeping them in the house. And opiates fall into this category. Okay? So here's your homework. What's in your medicine cabinet? So I did it. I got through it, Tanya. And now we can all go back to work. Thanks.